Okay, so this is the TOG article titled Care in Pregnancies Subsequent to Stillbirth or Perinatal Death. So this talk talks about patients who have already had stillbirth in their previous pregnancy, as to how to care for them, what kind of risks these patients have got, and so forth. So first things first, pregnancies following stillbirth have an increased risk of adverse outcome, including a 4.8-fold increased risk of stillbirth. Risk factors of stillbirth are things like obesity, smoking, advanced maternal age, fetal growth restriction, hypertension, and diabetes. Um, 2.6 million stillbirths were estimated in 2015 worldwide. The 10% of intrapartum stillbirth happened in high income countries, compared to 60% in South Asia. In the UK, stillbirth is defined as a baby delivered with no signs of life, known to have died after 24 weeks of gestation. There is six-fold variation in stillbirth between high-income countries, and you know so if you compare the Iceland to Ukraine, for example, the numbers are 1.3 per thousand in Iceland to 8.8 per thousand births in Ukraine. Um, so between 2000 and 2015, the annual rate of reduction in the UK was 1.4% per year of in the stillbirth rate. So that's good. Um, Stillbirths recorded were 1 in 270 pregnancies after 24 weeks of gestation. Um, Risk factors such as low socioeconomic status, advanced maternal age, essential hypertension, preeclampsia, antepartum hemorrhage, and fetal growth restriction. Um, so things like then it goes on to talk about some odds ratio. So, apart from APH and fetal growth restriction, the odds ratio for these risk factors were in the range of 1.2 to 3.5 fold increased risk of stillbirth. Um, there was the Stillbirth Collaborative Research Network in the USA found that only 18% of stillbirths happened in women with risk factors identified at booking. Pregnancy history was the strongest risk factor for stillbirth. A history of previous stillbirth is a recognized risk factor for stillbirth in a subsequent pregnancy. Um, so comparison with other risk factors, when you compare it with other risk factors, prior stillbirth has a comparable or a greater risk for stillbirth than many other risk factors. So that's quite important there. So, a large systematic review demonstrated that stillbirth rate is in 2.5% of women with previous history of stillbirth, compared to only 0.4% when previous pregnancy resulted in a live birth. So that's quite important. Um, Stillbirth recurrence was more likely when a maternal or placental condition occurred in the second trimester of the index pregnancy. There was also a trend towards increased risk of recurrence in women with diabetes or hypertension. So again, quite important information there. Something that you could perhaps be asked in an SBA, for example. Okay, so it then the article goes on to discuss some of the important things like establishing cause of stillbirth and classification of stillbirth. So it talks about, so there's 11 to 65% of stillbirth cases are placental lesions cause or are associated with fetal death. The post-mortem examination provided cause of death in 72% of cases, and placental examination helped to determine cause of death in 95% of cases, with cytogenetics helping in finding the cause in 29% of cases. So placental lesions can be broadly categorized into four groups. So you've got the inflammatory, the obstructive, disruptive, and adaptive. So obstructive are things like the maternal and fetal vascular malperfusion, and adaptive lesions like villus dysmaturity are most commonly they're seen in small for gestation, stillbirth, and fetal growth restriction live births. Villus Villitis of unknown etiology is associated with stillbirth. Incidence is 5.1%, and it's thought to be it's thought to be one of those causes that's recurrent. Particularly the CHI, which is chronic histiocytic intervillositis, which has a recurrence rate of 80% in subsequent pregnancy. Other multiple unrelated conditions are things like fetal thrombotic vasculopathy, cytomegalovirus, and gestational diabetes. The article then goes on to talk about care in pregnancies after stillbirth. So 67% of parents received additional antenatal visits, and 70% received additional ultrasound scans, and 10% had access to a bereavement counsellor. Parents who obviously have had previous experience with stillbirth have increased risk of intense anxiety, depression, fear, and complex emotional responses, and refrain from forming bonds with the unborn baby, as sort of a coping mechanism. 66% of parents who had previous stillbirth conceived with their subsequent pregnancy within 1 year of stillbirth. Okay, then if a woman stops to smoke before 16 weeks of gestation, the risk is the same as that for non-smokers. The role of ultrasound surveillance in pregnancies after stillbirth. So, women who are increased risk of stillbirth, especially because of an SGA infant, obviously there is use in using ultrasound. Abnormal blood flow through the uterine artery in the second trimester is associated with an increased risk of developing preeclampsia and fetal growth restriction. Both of these are associated with abnormal placentation and subsequent stillbirth. Abnormal uterine or umbilical artery flow within a thickened placental disc are associated with complications such as fetal growth restriction and stillbirth. So, what kind of so then the article talks about any medications that can be of use. So most commonly aspirin 150 milligrams once a night is prescribed before 16 weeks of gestation, as continued until at least 36 weeks of gestation. There is currently no high grade evidence to support the use of low molecular weight heparin to try and prevent fetal complications. However, patients who've got high risk of maternal venous thromboembolism, obviously low molecular weight heparin is prescribed and is currently used. The chorionic histiocytic, so the the condition that we spoke about earlier, which has a high recurrence rate, is quite, so it's CHI for short, and it stands for chronic histiocytic intervillositis. So basically, the article says that this is a rare placental lesion associated with poor obstetric outcome, and it's got high recurrence, as we've already said. And there's been a prospective multi-center study, and it talks about the number of live births increased in the treatment group from 32 to 67% when they had the quadruple therapy, which is aspirin, low molecular weight heparin, prednisolone, and hydroxychloroquine. So timing of birth, quite an important one. So increasing evidence shows that optimal timing for delivery for the general obstetric population is 39 weeks, because after this point, the risk of neonatal death does not fall, but the risk of stillbirth increases. There is a very useful flowchart, again given in this talk, which I will go through for you. So it talks about it's titled as Pathway for Care of Women Who Have a History of Stillbirth. Care is initiated from the time of death. Postnatal care is shown in purple boxes. Initial antenatal care is shown in green boxes, and care in dedicated antenatal service is shown in blue boxes. So death of a baby, investigations are done like postmortem, placental histopathology, maternal blood tests, postnatal preconception appointment, services are offered, and make plan for pregnancy. First point of contact, and then you've got your so the first point of contact is it's got 4 boxes to it. So it could be the community midwife, the primary care, the early pregnancy unit, or self-refer. You then commence them on appropriate interventions, booking appointment or dating scan between 11 and 13 weeks, followed with anomaly scan at 20 weeks. And then does the mother accept referral to a rainbow clinic? This is a specialized clinic in most of the UK centres, set up for patients who have previously had stillbirth. And if that's a yes, then the placental scan at 23 weeks, and the GTT so that's glucose tolerance test, if indicated at 26 weeks. Ultrasound scan will then be required as to monitor growth. If there's abnormal or placental screening, and then it might be done every sort of 2 weeks from 26 weeks, or if it's normal, then it might be done 3 weekly from 28 weeks. If there's any abnormality detected on scanning or screening, then further plans will be made about delivering the baby or monitoring and so forth. If there is no such thing and everything is normal, then plan of delivery more likely elective birth from 38 weeks. So that's all I've got from this talk for you. I hope this is very useful for you, as I found listening to audio versions of talks quite useful when I was revising for my exam. Please like the video and share and subscribe to my channel, so you can benefit from more content like this. Thank you for listening.